Right. The whole paclitaxel debate, it's been one of the biggest stories in vascular for the best part of a decade. Are these drug-coated devices a real breakthrough for preventing restenosis, or are we looking at an expensive tool with potential question marks? Well, today, for our most critical patients, we're getting a definitive answer. We are doing an examiner-level deep dive into the Swedepad 1 trial, a study that, I think you'll agree, is set to fundamentally change how we approach chronic limb-threatening ischemia.
So, we're going to tackle this systematically. We'll start by framing the clinical question with PICO, then critically appraise the trial's internal validity. After that, we'll get into the numbers, look at the headline results, consider the limitations, and finally deliver the verdict on what this all means for our day-to-day practice.
First things first, before we can judge the answer, we have to be absolutely clear on the question. And for that, we use the PICO framework.
And here it is, laid out perfectly. The population is tightly focused, adults with chronic limb-threatening ischemia. So we're talking Rutherford's 4 to 6. These are our sickest patients, the ones with rest pain, ulcers, or gangrene. The intervention was any paclitaxel-coated device, and this was compared directly against the standard, an uncoated balloon or a bare metal stent. And the primary outcome? It couldn't be more important or patient-centered. Ipsilateral major amputation. They absolutely asked the right question in the right group of patients.
Okay, so we know what they asked. Now let's look at how they did it. A trial's result is only as good as its methods, so we need to put the internal validity under the microscope and look for any potential bias.
The design is actually quite brilliant. This is a pragmatic, nationwide, registry-based, randomized controlled trial. Now, that's a bit of a mouthful, but every one of those words matters. Pragmatic and registry-based mean it's grounded in the real world, not some sterile, idealized trial environment. But the randomized design, with its intention to treat analysis, gives it that crucial scientific backbone.
The biggest strength? Embedding the whole thing in the SwedeVasc National Registry. This thing captures pretty much every vascular procedure in Sweden, so the population is a true reflection of reality, not a cherry-picked group. It also ensures proper allocation concealment. And, crucially, for hard outcomes like amputation and death, the assessment was blinded because they just linked to other national registries. Now, the key weakness, and it's an unavoidable one, is that the operator knew which device they were using. You can't really blind that. And that does open the door to a bit of performance bias. Maybe you follow up one group a little more closely than the other.
We should mention that this trial took a long time to recruit, nearly a decade actually. And that was partly because of a 15-month pause after that famous Cazzano's meta-analysis raised the mortality scare. But from a critical appraisal standpoint, the key takeaway is this. While all that affects your timelines and your final statistical power, it doesn't actually break the randomization. The comparison between the two groups is still fundamentally sound.
Right, let's get our heads around the numbers. You have to understand the statistical methods to really appreciate what the results are telling us.
So the investigators used all the standard, robust methods for this kind of time-to-event data. We've got Kaplan-Meier curves to show us how events accumulated over time, and for the main comparison, they used Cox proportional hazards models. And importantly, they adjusted these models for all the key things you'd worry about, like age, the vessel they treated, and even which hospital did the procedure. That makes the final comparison as fair as it can be.
And really, the entire trial boils down to this one number. This is the hazard ratio for the primary outcome, major amputation.
And here you have it. This is the money slide. The single most important finding. The hazard ratio was 1.05. But the real story, as always, is in that 95% confidence interval. It stretches from 0.87 all the way up to 1.27. And because that interval comfortably crosses 1, it means there is no statistically significant difference in the risk of amputation. The result is definitively, unequivocally neutral. But the story for reintervention is a bit more interesting. At 1 year, just as we've seen in other trials, the paclitaxel group did better. They needed significantly fewer reinterventions. But then, look what happens as time goes on. That benefit just melts away. The rates start to converge, and by 5 years, it's a dead heat. There's no difference at all. This really suggests that the drug coating might just be delaying the inevitable, not preventing it.
And now for the big safety question. Given all the history and controversy, this result is incredibly reassuring. The hazard ratio for all-cause mortality is basically 1, with a nice tight confidence interval. So in this very high-risk CLTI population, Swedepad 1 gives us really strong evidence that paclitaxel-coated devices do not cause excess late mortality. So let's pull all of that together. What are the definitive take-home messages, the things you'd say in an exam? First and foremost, the primary endpoint was negative. unequivocally negative. Paclitaxel-coated devices did not do the one thing we hoped they would in CLTI. They did not save more limbs. The whole central reason for using them in this patient group just wasn't proven. And if you look beyond amputation, the picture doesn't change. This chart makes it pretty clear. Whether you look at all-cause mortality or that really important combined endpoint of amputation-free survival, the outcomes were basically identical. No difference between the two groups. And for me, this is the point that really lands. Remember that early benefit in reintervention rates? Well, it didn't actually translate into anything the patient would notice. There was no difference in how much their Rutherford stage improved, and there was no difference in their quality of life scores. So we might have kept the vessel looking a bit better on an angiogram for a bit longer, but the patient themselves didn't feel any better for it. Okay, so how do these findings apply to our practice outside of Sweden? And let's be fair and acknowledge the trial's limitations. A massive strength of Swedepad 1 is its external validity. It's just excellent. Because this was a nationwide study of an unselected population, these results are about as generalizable as they get. What they found in this trial is almost certainly what is happening in our own hospitals.
But, no trial is absolutely perfect. The registry design means you don't get that really granular lesion-level imaging data. That forces them to use the endpoint of target vessel reintervention, which is a bit less precise than target lesion. They also used a mix of different paclitaxel devices. And it's worth remembering that patients only got into the trial after the wire had successfully crossed the lesion, which might exclude some of the toughest technical failures right from the start.
So, we've been through the question, the methods, and the results. What's the final verdict? What does this mean for us when we walk into the angio suite on Monday morning?
The message really could not be clearer. This is a high-quality, pragmatic trial, and it gives us no evidence to support the routine use of these more expensive, drug-coated devices if our goal is to prevent amputation in our CLTI patients.
And what this does is it forces us to take a step back and rethink our focus. It strongly suggests that saving a limb in CLTI is about so much more than just preventing restenosis in one vessel. Success probably has much more to do with the whole patient, with meticulous wound care, with the state of their microcirculation, things that a drug on a balloon just can't fix.
So what's the bottom line? Swedepad 1 is a landmark practice-informing negative trial. It's fantastic. It gives us a clear answer, and it reminds us to focus on what actually matters, real, patient-centered outcomes, not just chasing a pretty picture on the angiogram. For infrainguinal intervention in CLTI, the evidence is now clear. A plain old uncoated balloon should be our default strategy. This trial is a definitive pass.